Welcome to Bite-Sized Insights, a series of quick, live talks from a range of experts in data science and healthcare.
So next to me, we have a gentleman named Mac Davis. He's got 10 plus years of experience in managed care, serving as a leader in organizations like Roadmap, Cotivity, and Epic. And he is our data guru at Belong Health. So that is Mac and I, and I'd like to just kind of briefly introduce Belong Health, the organization that we are representing today, and what it is that we do. So we are an organization whose mission is really central to serving populations of folks who have highly complex needs. Thinking, groups like those that are eligible for both Medicare and Medicaid, and have been, persistently underserved by the healthcare system. So our goal is to really fill that niche. And we go about doing that by partnering with regional organizations and partner with them to stand up shared risk deals where we serve those really complex populations like special needs plans. So as part of that model that we have, it's really centered around the patient care, and our care management and customer service integration, I think, is really critical to that end, and to helping to drive better clinical outcomes for those populations like special needs, dual eligibles, et cetera. And realistically, central to everything that we do as an organization and the organizations that we partner with is the fundamental execution of risk adjustment and quality.
And most people that are not in MA, and even many of the regional and local MA plans we work with, don't fully appreciate how embedded risk and quality performance is across their performance in a variety of functions. Commonly, what people don't realize, if you don't perform well on risk adjustment and you really just care about providing the best service you can for your member, you're not doing risk adjustment to the same degree as maybe some other competitors in the market, you're losing out on potential revenue that's going to drive how you fund the benefits in your product. And it's going to change the way that you're able to present yourselves and provide for some of those members. Similarly, growth tends to drive significantly from your ability to fund those growth functions. And so without getting the revenue in, it's not possible to provide that. Provider engagement, I think, is very core of what we're doing with the Arcadia toolset to function. But people often think of risk and quality in its own silo, and they really need to think about it as a driving force for performance across all of the key stakeholders within their health plan.
Thanks, Mac. I think that's a great example of how critical risk and quality is to successful execution in managed care, and specifically Medicare. And I wanted to spend just a few minutes here talking through sort of the changing and challenging environment associated with that, and the real need for bulletproof documentation as it relates to supporting your risk and quality goals for your organization. So there's three big things that I wanted to highlight here. One is the implementation of the new V28 risk adjustment model for Medicare that I'm sure most folks here have spent a lot of time going through the call letter on. The next is around the RADV final rule, and finally, the updates around the STARS program for Medicare as well, Medicare Advantage. So starting with the V28 risk adjustment model, sort of migration to that V28 from V24. This is going to be a 3-year phase-in through 2026, but it will involve a significant reduction in the number of ICD-10 codes that tie to HCCs, or that ultimately risk adjust and impact your health plan's revenue. And then there's also the elimination of the incremental risk score capture for increased specificity within certain disease states like diabetes as an example. On the RADV final rule, have recently finalized the extrapolation of unsupported diagnoses that CMS has talked about for years. I think that this, beginning in payment year 2018, it's going to produce significant challenges for plans that haven't gotten ahead of this already. And now is the time to start focusing on making sure that your documentation and the associated diagnosis codes that are being submitted for risk adjustment are 100% accurate, because reality is that's the expectation from CMS. And then finally, on the RADV final rule, the exclusion of the fee-for-service adjuster, again, is just another example of increased pressure on plans and not getting the same maybe accommodation as on the fee-for-service side. So relative to STARS, there's 3 new sort of utilization-based measures: transitions of care, follow-up after ED visits for patients with multiple chronic conditions, and plan all-cause readmissions as well, beginning in measure year 2022. And in addition to that, there's a number of other sort of programmatic changes coming in the way that STARS ratings are calculated. One example of that is the implementation of the Tukey outlier deletion method, which again will remove the propped up performance for higher performing plans by removing those from the calculation that performed more poorly. So what's the punchline here? The need has never been more clear and critical to make sure that documentation is 100% accurate, that your diagnosis submissions and everything that you're doing around STARS or quality is reflected in the medical record and can be validated, when it's ultimately audited. And, one way that we go about doing that is by promoting the completion of annual wellness visits. And, I think that there's many reasons why an annual wellness visit is a great example of ways to drive better clinical outcomes for, Medicare age type population. Listed those out here. It certainly helps to encourage that relationship between members and providers. When we think about, special needs plans as an example, there's a number of challenges just with getting a hold of our members, coordinating a visit with the PCP, but we feel that that's really critical. It also allows us to make sure that we're getting a comprehensive and complete documentation for all code submissions and quality gaps, and then also promotes the completion of health risk assessments. Related to annual wellness visits, one way that we've helped to promote higher quality documentation during those encounters is through leveraging a tool called Arcadia Assess, which helps to surface chronic and suspected conditions as well as open quality gaps for that specific patient, and provides medical record documentation for the provider to address during that encounter. It is really critical for us to ensure that we're getting that comprehensive diagnosis and quality documentation.
And we've had some massive success in the last year. We've increased our annual wellness visit rates in our population by over 122% from a previous year. And that's driven a significant number of underlying business performance across many of each of those 3 angles on that triangle slide. Starting with growth, we've had a vastly different experience in AEP, more than doubling our membership year over year that joins our health plan. We are a 5-star health plan that allows us to also enroll members year round, which is probably the biggest advantage of being a 5-star over a 4.5-star plan.
That's right.
And then significantly, we've driven a huge number of adverse utilization events down by making sure we're enforcing really comprehensive and deep relationships with primary care providers. So a 65% increase in PCP visits versus geographic benchmark. Not all utilization is bad. And we think that we look at that as being one of our biggest success points in the first year in our DSNP population, all while figuring out how to beat an 80% MLR target, which is by far best in class for any MA health plan. I would challenge them to go toe-to-toe with us on that. So a lot of that's being driven by our annual wellness visits that we're performing today and our focus on that. But obviously it takes a vast team of people behind us to execute on. So I think with that, we will answer whatever questions may exist. Yeah, so besides annual wellness visits, what are we doing for patient engagement? I think we've embedded our focus on wellness visits by we use a process called behavioral design. So basically, we have mapped out. I think everyone 10 years ago said they've mapped out their member experience journeys, and that was kind of a buzzword people said at HIMSS, right? And the results of that were highly mixed. The difference of what we're doing is we're using like some more of a behavioral economic incentive structure to say, how do we make making the right choice the easy choice all along that pathway from the moment we do a welcome call with a member when they come on through the point that we're influencing them to go see the doctor themselves so that we don't have to go make that schedule for them, to towards the end of the year where we're being more aggressive on making those appointments. And aggressive is probably the wrong word, but we're being a little bit more suggestive in the actions, because it's much more powerful if you can convince someone to do the right thing for themselves than doing it for them. I think it goes back to making sure that we are making the most of every encounter. And so it's a large part of our strategy is first call resolution. So our populations are highly complex. There are lots of issues. In New York, we've got a coordinated SNP that people are in. We're launching a fully coordinated options when the state finally starts approving them again. It's like, I think, the first one on their desk. But what that means is that these members have two insurance cards. They've got a Medicaid card and a Medicare card. And if they lose one, knowing how to go to the hospital, they feel like there's a barrier, right? So if they call in and they're talking to a customer service manager or their community social worker, we want those people to be able to act and solve every single one of the problems that they can for that member right then and there, so that there's no excuse or barrier to that person to go get that thing that they really need. And sometimes it is as simple as an ID card. Sometimes it's a lot more complex, like they just don't have transportation, or they don't have access to healthy food, or they are secretly taking care of 4 family members and they care more about their family than themselves, right? And so it's getting to what is that problem and barrier that's preventing them from doing the right thing, and then how do we support them in making the decisions they need for their own health, and also in that last example, the things that are actually going to be best for their whole family unit.
And just to add to that a little bit, so there's certainly some tactical things like member gift cards and whatnot that you can do to promote that, sort of adoption of the, annual wellness visit type of process. But I think, at least as important is understanding the practices that you're working with and the specific barriers and challenges that they have, recognizing that primary care is a challenging environment to be operating in today, and time is limited, resources are limited, and there's certainly a lot of pressures on the groups that we work with. So understanding what those challenges are and then building out, really tactical and tailored solutions for each practice, I feel like is critical.
Yeah, so the question is, how are we communicating these diverse interventions across and goals across a large network where there's a variation of need? Is that okay? I think there's a couple ways that we do this. On provider performance specifically, I think every provider kind of thinks of themselves as their own special situation, and many payers will look at them and say, oh, I need to treat every provider practice as an individual. And what you're really looking to try to do is build operational executional trust with those providers around the things that matter most for top line mutual performance, right? And so historically, a lot of payers have struggled to get buy-in on the things that actually drive the business. So they'll say, oh, this quality measure of an A1C is really important, and that's what everyone can agree on. But that's not the thing that's going to drive an 80% MLR. It may drive one measure among a dozen in quality, but so it's relevant, but it doesn't cover the scope of things necessary to be successful. And so our approach is generally to focus on the areas that are tied to revenue, quality, and member success at a broader scale, so that when we're interacting on something with a member, we're not just talking about an A1C test. We're talking about diabetes management and all of and weight management and glucose monitoring, all the things that has to do, rather than focusing around a specific measure. But that does mean we're creating like a templated approach to all of our providers, and then pulling specific levers to provide controlled customization for each engagement. Because if everyone can go pick their own measures that we're going to measure a provider practice on, or a subsection of a population on, we would not be an effective executional partner to help scale that across our whole network. And so there has to be a balance between the two. So the question is like, how big is our organization, and how have we like structured to support some of these outcomes? I think there's two, like we are a fully remote company, or fully distributed company, I think is the sexy remote work term I'm supposed to use. But what that means is our focus is on having in-market care teams, because we fundamentally believe that healthcare is local. So where we launch our health plan products, we've got boots on the ground that understand, hey, it's kind of hard to cross that 5-lane road that you're not going to get with a remote resource. In some cases, because our members have sometimes, or some of the sickest and least capable, most at risk members, it is very efficient for us to actually go into the member's home to provide extra support for them, or just do a home visit to develop some of that executional trust with the member itself. So our teams are integrated with care management, customer service, nurses, physician, pharmacist, and the member knows a lot of the names of the specific people that are taking care of them. And then we use our technology stack to basically help scale the effort that single team can accomplish. And that kind of hybrid, they're local, but they're interacting over the phone with those people in their community. And when necessary, they're getting out and going to see people physically. Our analytics teams are centralized in the org, kind of across markets, but we have market-specific focus. So when we're working with provider groups, it's not just, hey, analytics has to drive the insight. We expect our network ops team to be able to analyze data, and to the point of saying, these are the important things that drive performance. It's making sure that every person in our organization knows what that model is, so that they're not going off the rails and choosing the A1C level that's important for some things, but doesn't ever move the needle in totality by itself, right? So it's proportional focus on the things that matter, and making sure we're very disciplined across our whole org for that. And that's exponentially more powerful than our staffing model and overall size.